And good evening and welcome to everybody to this week's edition of Maternity and Midwifery Hour. My name's Sue McDonald and I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. And it's my pleasure to be hosting this session this evening. And I've got a lovely speaker called Vaishali Swardi. I hope I pronounced that correctly, Vaishali.
Yes.
And here she is. And I'm going to ask her to share her moment of the week, which is a bit delicious, I think.
Mm. Thank
Welcome.
you, Stu. Thanks for inviting me, and good evening to everybody. Um, the moment of my week was when I went to London just 2 days ago. My son's got a promotion. He works in the civil service, and he took me out for a lovely dinner. So I think that was really lovely. That was the moment, or just made my whole month.
I should think it made your heart. Isn't that a lovely though?
Mm.
That must make your mum heart just swell with pride. How fantastic. That's
Yeah,
a
it
lovely
did.
moment to choose. Now, you see, normally we'd have two moments. The only moment I can think is I had to draw the curtain this evening because now the evenings are drawing in.
Mhm.
It means that autumn is coming. And I get a bit sad about that, but that means that spring's coming, winter's coming, and then summer will come again. So you can be positive about it. Anyway, thank you for that, Vishali. Now I'm just going to do a little bit, and I know that there are some new participants this evening, and welcome to you to this evening, and I hope you enjoy it. I know you will. Also, welcome to our usual gang of people we have who come all over the world come in and listen to us and participate and send us lovely questions, which I hope you'll do this evening. And it's for me, it's amazing. We're now in our fifth year of doing this maternity midwifery hour. We started in the lockdown in the UK for COVID in March 2020. And we at that point it was about getting midwives and student midwives in touch with each other and getting information out because it was a time when we couldn't meet at conferences or study days. We focused very much on clinical work and just keeping the service safe for women and babies. That I'm focusing obviously on maternity services just now. And there was you can forget how scary that time was, but it was scary, and people wanted lots of information, and people wanted that contact. Um, the only place you get, it's the contact that you get from a conference is so special because it's that community, that family of midwifery and midwives which I was reminded of yesterday, actually, but that's another story. Now, just also, we've carried on with this, and we don't do quite as much about COVID. We look about general things around midwifery and maternity, about refreshing our knowledge and just updating, challenging a little bit, and just being able to talk about issues that this might be difficult, might be uncomfortable, or might be very exciting if it's new research, for example. Um, we've carried on, and we do. And one of the great things about Maternity and Midwifery Forum is that we record everything. So if you should have a power cut or a mouse eats through your internet cable, which has happened to one of our participants in the past, it doesn't matter. You'll be able to catch up later. And you also can get, if you can't have to rush away, you can get access to this presentation tomorrow or next week when the newsletter comes around, and you can share with your colleagues. And we like to share. It's really important. And I'm a bit fixated on this as a teacher because when you get new knowledge, it's really helpful if you talk over with people and share what you've learned because it kind of concretes in your brain, adds to what you've got in there, in that big filing cabinet of a brain. So do share. And I'm going to say just now, look after yourselves at the moment. There seems to be a horrible load of bugs around at the moment. And I know everybody keeps saying that, but it just seems there's just nastiness and colds. And I think there's a new variant of the blooming COVID. So look after yourselves and do all the things you need to do about rest, eating properly, and all the other things we need to do to keep well. Now, news. We had the festival for Wales and the Southwest yesterday in Cardiff, which was lovely yesterday. Real good buzz. A few students and quite a few midwives actually. And the sunshine shone on us, and that was lovely. Bit chilly, but it not in the room. It was lovely and warm. And we had some fantastic presentations. We started with the Welsh government, what they're doing to support midwifery and support and develop it. We looked at decolonisation, which is a huge thing for us in education and practice. We looked at respectful care. We looked at newborn sequencing of the genome. I might need to look at that presentation again. And also about how best to support autistic people who are pregnant and childbearing, which was really useful. Lots and lots of other presentations. And if you manage to get the box set, I'm sure you'll be dipping into that fairly soon. Now, in our resource sheet this week, I've included a lot of what Vaishali has sent. She sent loads and loads of links, lots of internet resources, which are fabulous. But I've also included the latest Embrace report and the National Perinatal Audit report, which are both really important for us to read and absorb and share and discuss, because both have implications for improving our practice and improving the kind of offering we give women and babies. Now, the other thing that's big news, big news, is paracetamol has been accused of being responsible for autism in children. And this was, I think, announced yesterday at some point, and a little bit shocking because paracetamol is one of the few things that pregnant women can have. And funnily enough, if you do a little search for research and evidence for the use of paracetamol, you will find it is pretty safe, if not very, very, very safe. And in fact, there's a very good piece of research that's on your list. Of course, it's called acetaminophen use during pregnancy, and it's paracetamol because that's the name that we use. That used during pregnancy in children at risk of autism, ADHD, and intellectual disability. It was a huge, huge study, and I believe it was 4.1 million cases that were looked at. I might have the numbers wrong. I'm still dipping into it, but their conclusion was that the use of paracetamol during pregnancy was not associated with children's risk of autism, ADHD, or intellectual disability in sibling control analysis. So this is well worth reading because this is the evidence that you need to make sure you're sharing with women, because any woman who's pregnant must now think, oh my goodness, I can't even have a paracetamol. But it's safe. But obviously we as midwives need to encourage women to express if they're concerned and actually talk to us about it, or talk to their GP if they prefer, just to make sure they're clear on what is safe and what is not. It's kind of worrying when people announce things, and I think for me it really underscored the importance in our practice of evidence, strong evidence and research. And we know there's a whole load of stuff that still needs research and evidence, but there's an awful lot of stuff that we've got where we've got the evidence and we need to be using it. So I'll get off my soapbox now, but it's there on your list and it's got a link so you can get in to read the whole thing. And if you initially just maybe read the first summary abstract, because then you'll get a feel of it. And when you're feeling you've got a nice cup of tea and a biscuit, then read the whole thing. Fabulous. Okay. Now this week we are looking at sharing the news that baby has a Down syndrome and how we support families. And this is really important for us as midwives and student midwives, if you're involved with supporting families, to really provide support and also signpost what services are available, what extra help is available out there for parents with children with Down syndrome. I'm really so pleased to introduce Vaishali Svadi. She's going to include a video clip from a mum from Bev Inch, who's a parent of a child with Down syndrome. Vaishali is the professional engagement and development lead at Down Syndrome Scotland, where she leads on training, professional engagement, and resource development. So it's quite a big task, I think, all across the education and health sectors. She's got over 20 years experience in the third sector. She's contributed to national work on neonatal and healthcare pathways for babies with Down syndrome, and she supports inclusive practice in schools through tailored training and resources. I'm very impressed by her here. Fluent in English, Marathi, and Hindi, and holding level 2 BSL. She brings a strong communication cultural insight to her work. And Bev is a mum of three girls and works part-time in primary school teaching. I'm introducing them together because Bev is very much part of Ashali's presentation. So welcome, Ashali. Thank you so much for coming this evening. The screen is now yours.
Thank you, Sue. Thank you so much for this opportunity. Good evening, everybody. Sue's already introduced me, so I'm not going to spend time doing that. I'll just bring up my slides and we will get cracking on. So hopefully my technology skills don't fail me. I'm going to start the slideshow, and hopefully it all works for you. Okay, assuming you can all see the slides. Perfect. Okay. So this is just a mandatory slide. I'm required to show it to you because all our training is CPD accredited. So you can ignore this one or you can just read through it quickly. What we're going to do today is talk a little bit about Down syndrome. So you're going to hear some good practice examples, some feedback that we've collected from our families. You will learn a little bit about Down syndrome, so a little bit about the history, some of the health issues that impact people with Down syndrome. I have included the learning profile, but I know I only have an hour, so I'm not going to include a lot of this information. I might just show you the slide quickly, but we will talk a little bit about the health issues and understanding how to support families in that neonatal period or when in the early years, and the support that we offer as a charity as Down Syndrome Scotland. And then you also get to hear from Bev, who is our parent volunteer. So that's sort of what I'm thinking of for today. So I'm going to start with a little bit of history. So we know that Down syndrome has been around for a long, long time. During the Neolithic period, there was a grave of a baby that was also discovered. In the 1500s, there were some old paintings of people with Down syndrome that were found. But it's only in 1859, there was a doctor called Dr. John Langdon Down, and he studied some children in an institution near Normansfield. He got very interested in these children because they all displayed very similar physical features, characteristics. So it is after Dr. John Langdon Down that Down syndrome is now named. But it's only in 1959, there was a French professor who established that Down syndrome is actually caused because of a genetic condition. So until then, we didn't know why it was caused. So we do know now that it's caused because of a genetic condition. It is a congenital condition, which means it happens at birth. It's not an illness. It's not a disease. It's not something you can take away. The reason I'm mentioning this is because often when parents get that initial diagnosis, that can be one of the questions they ask you. Is it something I have done during my pregnancy or conception, which has caused me to have a baby with Down syndrome? So it's just to reiterate that it's nothing they have done. It is a purely random event, and anybody could have a baby with Down syndrome. Now, there are 1 in 1,000 babies born worldwide with Down syndrome. And in Scotland, the number is roughly 60 to 70 babies born every year. And that's just based on some of the data we've collected, based on our membership, based on the referrals that we get. So roughly around 60 to 70 babies born every year in Scotland. We know it's caused because of an extra chromosome on the 21st pair. And usually I would make this a very interactive session and ask you how many types of Down syndrome there are, but there's no way for me to find out if you respond to my questions. So I'm just going to tell you there are 3 types, and I'm going to stop sharing this slide and I need to bring up the whiteboard. So I have been asked to keep talking while I do that. So there is not too much lag. So let me see how I can do that. Just trying to bring up the whiteboard, which is a little bit fiddly, but sorry, it's some reason my screen is playing up. There you go. I will bring up the whiteboard. Let me know if you can see it. Okay. Can you see a screen with an attempt to draw some circles on it? I'm assuming you can. Perfect. So the circles I've drawn here represent the cells in our body, and in every cell of your body, we have 23 pairs of chromosomes. So it'll help if I pick up the pen. There are 23 pairs of chromosomes in every cell of the body. I'm not drawing 23, but imagine there are 23 pairs of chromosomes in every cell of the body. One which comes from the father, one which comes from the mother. Now, when somebody has a first type of Down syndrome, which is the commonest form, it is known as trisomy 21. You might have heard this word, trisomy 21. Often people refer to Down syndrome as T21 or trisomy 21. Technically, may not be the best way to describe Down syndrome because it's one of the types of Down syndrome. So when somebody has trisomy 21, what basically happens is on the 21st pair of the chromosome, you'll have a whole extra chromosome. And that happens in every cell of the body. The 21st pair will have that whole extra chromosome. This extra chromosome is actually an excess protein which mom produces during pregnancy. It's called the amyloid protein. And it is this protein that gives some of those physical features that you see in somebody with Down syndrome, like the almond-shaped eye, shape of the face. Now, it's important to say trisomy 21 because there are other genetic conditions where the 13th, 14th chromosome could be impacted. Down syndrome is always associated with the 21st chromosome. Another useless fact, that's why we celebrate World Down Syndrome Awareness Day on 21st of March, because 21 represents that 21st chromosome, March because March is the third month representing that third extra chromosome. So if you didn't know, World Down Syndrome Awareness Day is celebrated on 21st of March for that reason. The second type of Down syndrome is known as translocation. Now, translocation is quite rare, affects about 4% of the population. And when somebody has translocation, in about 2/3 cases, either parent could be a carrier of that extra gene. So it doesn't mean that the parent has Down syndrome, they're just carriers of that extra gene. So when cell division takes place, that little chromosome translocates and attaches itself to that 21st pair. So it's not a whole extra chromosome, just a tiny bit which is translocating and attaching itself to that 21st pair, either on this side or this side of the 21st chromosome. So usually when somebody gets a diagnosis of translocation, the family will be offered further genetic testing because there is a high chance that if they go on to have any more babies, they could possibly also have Down syndrome. So that's the second type of Down syndrome. Now, somebody with trisomy 21 and translocation will display more or less the same physical features, characteristics. They'll usually have mild to moderate learning disabilities. And the last one is known as mosaic Down syndrome. Now, mosaic is very, very rare, affects only about 1% of the population. When somebody has mosaic Down syndrome, what basically happens is you have your cells and you have those 23 pairs of chromosomes. On the 21st pair, you have a whole extra chromosome. So it looks quite similar to your trisomy 21. The difference is it doesn't affect all the cells in the body. So some cells continue to have the 46 chromosomes, and some cells will have that extra chromosome, so they will have 47 chromosomes. So it's like a mosaic. Now, usually when somebody has a mosaic type of Down syndrome, they may not display all the physical features or characteristics that you see in somebody with trisomy or translocation. And with the mosaic type of Down syndrome, generally, they will have milder learning disabilities as well. But it's important to remember that Down syndrome is a spectrum condition. So you can get people who are very high functioning, but you can also get people who have lots of complex learning disabilities or needs. So that's the three types of Down syndrome. Just going to stop sharing and bring up the slides again. And hopefully they work. Sorry, this is really fiddly to do that, but I haven't figured out any other way to use the whiteboard on Zoom. Not yet. So, okay, let me know. I'm going to bring up the presenter view. So can you see the slide which says characteristics and health issues? I'm assuming you can because I can't see anybody else. Okay. So I'm going to talk a little bit about the characteristics and health issues. So we know that when I talk about characteristics, these are generic characteristics. So you will not see them in every child that you come across, but I'm just going to talk about some of them. So one of the ones you might notice is hypotonia or muscle tone. Now, generally, people with Down syndrome, or when babies with Down syndrome are born, they can have low muscle tone, but not always. Some babies will have really good tone. They'll be able to hold their neck and head properly. But some babies might have low muscle tone. So muscle tone is a resistance your muscle has to any kind of movement. Usually when the child learns to sit up, often you might notice if they're sitting on a chair, if their feet are not planted on the ground, then they don't have a lot of core strength. And that's when they can sort of slump forwards on the chair or slump backwards. Usually we would recommend getting input from an occupational therapist. They can provide the child with a specialist chair, just gives them better support when they're sitting. Oh, sorry. Okay. Mm. Now, okay. Can you see them now? So I hope you heard me though when I talked about hypotonia. Uh, the other one is with regards to vision. So about 60 to 70% children can have issues with their vision. Usually it's long-sightedness, short-sightedness, which can be corrected with glasses. Sometimes they can also have what is known as visual acuity, which is to do with the cornea in the eye, and that prevents them from focusing properly. So if you have like a computer keyboard, the black keys, white letters just looks like a blur, or if a book is lying flat on the table, it can look like a blur. And visual acuity is not something that can be corrected with glasses. So usually some modifications, as in using colored keyboards, using sloping boards, using yellow paper rather than white paper, all these things can make a huge difference to that child. They can also have issues with their peripheral vision and depth perception. So when they're coming down steps, usually it might be tricky to know when one step starts and the other one ends. So there are lots of things that OT can provide. They can put low colored treads on steps, low railings. So all these little things will make a huge difference to a child if they have the visual acuity. Hearing again, 70 to 80% children can have issues with hearing. Now, babies, when they're born, they usually have very narrow eustachian tubes, but in babies with Down syndrome, they are even narrower. And that's why you'll notice that the mucus doesn't flow easily. So they have frequent colds, upper respiratory infections are very common. Um, the middle ear canal also gets blocked, causing a conductive hearing loss or glue ear, as it's commonly known. So these are some of the common sort of issues which you might notice in babies and children with Down syndrome. With the mouth area, you'll notice that the oromotor muscles can be quite weak. So particularly for babies, sometimes latching on when breastfeeding can be quite tricky, but that doesn't mean they can't breastfeed. And I will share a couple of resources later on as I talk about breastfeeding. But sometimes chewing, swallowing, biting can be an issue because of the low muscle tone. And if they're not weaning, if the child is say 4 and 5 and still eating mashed up food, then it's really important they get input from a specialist speech and language therapist because they can assess their bite and swallow. They can also have issues with reflux. So we have a muscle called the epiglottis, which shuts when you take food in. If that muscle doesn't shut properly, the food comes back up your food pipe or enters into your windpipe, causing the child to either choke or to sort of splutter. So again, all these issues need to be addressed. So input from a specialist speech and language, right from when they're born and in the hospital. If they have need that input, it should be the timely input is really important because our mouth muscles are really important. These are muscles we're going to use for production of speech sounds as well. So if these muscles are weak, it can affect clarity of speech. Metabolism is also slower in people with Down syndrome, and that's to do with that amyloid protein we talked about. So the basal metabolic rate for people with Down syndrome is much lower as compared to the typical population. So they do have a tendency to put on weight. So generally controlling portion sizes is what we would recommend. Thyroid, again, is a big issue for a lot of people with Down syndrome and either hypo or hypothyroidism. So high or low levels of thyroid, and it can be corrected with medication. So usually when babies are born, they will get a thyroid check, they will get a hearing and a vision test, and they should get these tests on an annual basis, vision, hearing, and thyroid. So this is something recommended by the Down Syndrome Medical Interest Group. It's advisable that all families should get this for their children, vision, hearing, and thyroid. And thyroid, as you know, is really important. It can affect memory function, it can cause tiredness, sudden changes in behavior. So all these things are really important. About one third of babies born with Down syndrome can have a congenital heart condition. So they can have either a very minor hole which can close itself, or they might need surgical intervention, or some children might need intervention from the cardiology team even at a later stage. So that is to do with the heart. Sleep, again, is a big issue for our Down syndrome population. And there's been a lot of research done on this. So one of the things is that people with Down syndrome produce less melatonin, which is a hormone that helps us to stay asleep or fall back to sleep. So often parents do tell us the child wakes up really early. They're awake right from, say, 3 o'clock, 4 o'clock in the morning, and they can't fall back to sleep. Some children can also have sleep apnea where the oxygen levels dip at night, so they might need sleep studies done. They might need to wear a CPAP mask. They can also have what is known as silent reflux. So you don't see any symptoms of reflux during the daytime, but when you're lying down, your internal muscles relax and the acid from the stomach comes into your mouth, causing the child to waken up. So again, lots of parents tell us the child is sitting up and sleeping rather than lying down because of the discomfort. So all these things need to be investigated. They need to have sleep studies done to investigate this, because sleep is so important, as you know, for development, growth. Um, Gut health, again, is a very important one for our Down syndrome population. Uh, Constipation is a very common one, because the peristaltic movement that happens when you pass your bowels doesn't happen that easily if the internal muscles are quite lax. So we have children where they haven't passed a bowel movement for a day, 2 days, sometimes even a week. They could be in pain, there could be discomfort, they're not able to communicate that to you. So again, these are things that need to be addressed. Celiac disease is also more common in children with Down syndrome. So again, that needs to be investigated. Really important, because something like celiac, if it's left untreated, can cause lots of issues like diarrhea. It can also cause behavior issues in children. So it's really important that these issues get investigated early on. With the hands, you'll notice that the babies or children with Down syndrome can sometimes have what is known as a palmer's crease. So this crescent shape you see is a flat line. It's sometimes one of the markers doctors use when they diagnose a baby with Down syndrome, but it's only one of the markers. Not everybody will have the palmer's crease. They do have low sensitivity on the palm, so they can appear quite heavy-handed. So when they're pushing a door or calling somebody, you might feel as if they're going at it really hard. It's just that they don't feel the sensation. And obviously, because of the low muscle tone, sometimes the fine motor skills can be impacted. So doing things like zips, buttons can be quite challenging. So lots of opportunities to practice that. Gross motor skills can also be impacted. They can walk with a wider gait. They can have issues with balance when they're walking. Some people can also have flat feet. So again, using orthotic shoes, all these things can make a difference. In terms of height and stature, you'll notice people with Down syndrome are generally smaller than the typical population. The average height for women is about 4 feet 11 inches to 5 feet 2 inches. And for men, it's roughly 5 feet 2 to 5 feet 6. But remember, it's only the 21st chromosome that's different. Rest of the chromosomes come from their family genetic pool. So they will take on characteristics of their family members. Cervical spinal instability, this can, I'm not going to explain what that is. I'm assuming you're all midwives and probably more aware of what this is than I am. But in just layman terms, imagine this, if you can see my hands, imagine this is your vertebral column, and this is the bit that holds the back of your head or your neck, and your spine runs in the middle. If there is excessive movement in the first and second vertebral column, it can cause injury to the spine inside. So It's not a given that just because you have Down syndrome, you'll automatically have CSI, but it's something to be aware of. The child or adult will display other symptoms. It might affect their gait. They might have issues with balance, but it has to be assessed by a medical professional. Obviously, with age, sometimes they can develop CSI because of degeneration as well. And osteoarthritis is also more common, even at a younger age in children with Down syndrome. Dementia. Um, if you remember, we talked about the amyloid protein that mom produces during pregnancy. Some forms of dementia are caused because of the amyloid plaque on our brain. And that's why for our adult population particularly, we do ask early assessments for dementia as early as in their 30s and 40s, because they're more prone to getting dementia, early onset dementia, and dementia tends to progress much faster in people with Down syndrome as well. They also tend to age much faster than the typical population. So about aging is accelerated by almost 20 years. So if you have an adult who is, say, 40 years old with Down syndrome, he will be like a 60-year-old typical adult. So aging is accelerated. However, they will hit puberty at the same stage as every child. So biologically, they will hit puberty at the same stage as a typical child. So that's generally the sort of health issues characteristics. I haven't touched on a lot of them that are particularly for adults, but these are generally what you might come across if you have a child with Down syndrome on your caseload. Learning profile, I really don't have too much time for that, so I'm not going to go into it, but generally, they do have a very unique learning profile. There's a lot of research done by neuroscientists on how the brains of people with Down syndrome develop, but you can come on to our full-fledged sort of teaching sessions and you'll get more on the learning profile as well. I was going to do a little bit of busting myths, but again, I cannot see the chat box, so I'm going to ask the question and I'm hoping maybe only Sue can answer me and then I can give you the answer. So my question is, babies with Down syndrome are all born to older mothers. Sue, any thoughts on that? You're right. It is not true. So you'll be surprised to know 80% of babies are born to women under the age of 35. The statistics is skewed towards older women because as women get older, they get more tests offered. But you can have an 18-year-old mom who can have a baby with Down syndrome as well. All people with Down syndrome are happy and loving.
I'm not sure that you can make that generalization.
You're right. So absolutely. It is a very cliched statement, but we often hear it from a lot of health professionals, where they'll say, oh, all babies, all kids with Down syndrome, are they always happy? Well, that's not the case. They have the full range of emotions like all of us. In fact, they can be very, very sensitive to failure. People with Down syndrome don't live as long as other people.
I think that's true.
So there is an element of truth to that. The average life expectancy is 60 for people with Down syndrome. But if you remember Dr. John Langdon Down, when he studied those children in Normansfield, life expectancy was 9. So we have come a long, long way, and that's because of all the medical advances, supports out there. Outcomes for people with Down syndrome are much more positive. The oldest person in the UK is 76 years old. So you can see that life expectancy is improving. People with Down syndrome cannot read or write.
It's on the degree of on the spectrum, doesn't it? I think
Uh,
high
that
functioning, low function.
Yes, there is an element of truth, maybe a little bit, but it also depends on how much they're exposed to these to reading and writing. Uh, but in general, people with Down syndrome are strong visual learners. You'll be surprised to know they learn to read first before they learn to speak, which is like the other way around for us because they're so visual. They learn by the sight word or the whole word approach. And there's a lot of research which backs this up. So we know children who have been exposed to lots of alternative augmentative forms of communication, by the age of 12, they can become voracious readers. But obviously depends on the exposure they get to it. People with Down syndrome cannot hold down jobs.
I think they can
Yeah, and it's not
as much as anyone else, I guess.
absolutely, and it's not people with Down syndrome. It's often attitudes of other people which are barriers to employment for our people with Down syndrome. So they have the same dreams and aspirations like all of us. Adults with Down syndrome are childlike.
I'm not sure. I think it depends. I think it would depend. My knowledge. I mean, they might have more innocence in some ways, some, but I think it would depend on their degree of effect.
So they should be treated age appropriately, and
Mm.
there are lots of reasons for that because they can be very vulnerable. They don't understand boundaries, so they won't understand why is it okay to hug my mom, but it's not okay to hug this stranger I've just met in Tesco, because for them everybody is the same, and that's why teaching those age appropriate behaviors is really important so that they understand those boundaries and it's for their own safety as well. Okay, so that was a bit of busting myths for you guys. I just wanted to share a piece of research which was done by Warwick University in 2023. And in England, the Care Quality Commission, they kind of host this, um, they keep a track of maternity experience annually. And they found out that women who had babies, in general, 85% of women felt supported. But when they were given a specific diagnosis of Down syndrome, that support fell to 37%. We don't have any equivalent sort of survey done in Scotland, but the Scottish government does publish the Maternity Care Experience Survey. And the most recent one was in 2022. And again, the figures were quite similar to what I have just shared with you. So 85% who didn't have any diagnosis felt supported, but that number fell when they had a specific diagnosis of Down syndrome. It fell to 37%. So these findings show how urgent it is. There is an urgent need for training and positive language and trauma-informed care in the maternity services. So moving on, I just wanted to share some feedback from our families, some really good quotes and some not so positive feedback, but parents have actually told us what it is that they would like to hear from the maternity services. So one of the things families always say to us is always knowing you're there is reassuring. The midwife that delivered her, she has some pointers, but she's very beautiful and she's yours. She sat and talked to me for hours after having her, answering my questions and just being there whilst I took it all in. She also came to see me 2 days later after tests confirmed Down syndrome. She was wonderful and I couldn't fault her. So you can see how important this is for families. Just you being there for them, answering their questions, and reassuring them. Your dedication and support makes a big difference. Also, one of the midwives, who all happened to be a male, really stood out in our aftercare after he was born, telling me how amazing he'll be, the sparkle in his eyes and focusing on all the good about it. In the first few long nights, while still in hospital, overwhelmed at having this new life to look after alongside the unexpected diagnosis, he was a much needed friend who spent far longer with us doing OBS, etc., than any of the others we saw. So again, you can see how much going a little bit over and above has made such a difference to this family. Your kind gestures and thoughts mean a lot to us. Midwives on the postnatal ward were amazing. They let me and my partner stay in a private room for 7 nights post-birth. There was nothing physically wrong with me, but I think this was to allow time to process the situation, access the breastfeeding support, and also so they could keep an eye on my emotional well-being. One day I returned to my room and a midwife had printed out "Welcome to Holland" and left it on my bed, which I thought was a lovely gesture. So I don't know if you've heard this story about Welcome to Holland. Um, it's about somebody who has planned a holiday to Holland, but they actually end up going to some other place in Sicily. So it's like you have this vision that you're going to have this perfect baby, and your life is going to be perfect. And then life takes a different turn and you start a new journey in your life. So it's something along those lines. So I think these little gestures mean a lot to the families. Now, some of the feedback we got, okay, this one, better knowledge means better support. The breastfeeding specialist midwife was fantastic and basically giving me one-to-one support nearly every day for the 13 days that Alice spent in the unit. She told me there's no reason why she can't breastfeed and offered to put me in contact with other parents she knew who had children with Down syndrome. So again, just having that support means a lot to the families. Now, taking time to use the correct language matters, and you'll see us talking a lot about this. You'll hear it from our parent speaker as well. So low ears and less lines on hands. And when asked what that means, are told it could be a syndrome. We have seen some possible markers for Down syndrome would be a better way of putting it. So rather than saying things like low ears, or we've had cases where the family's been told the baby has dysmorphic features. Now, if you're not a medical professional, these sort of words you don't know what it means. So just mentioning to the family that you have seen some possible markers for Down syndrome is a better way of putting it. Your words are remembered forever. Well, it's clear she's Downs. There are obvious dysmorphic features. Please be careful on what words you use. As parents, we remember them forever. And again, you'll hear that from our parents all the time. We've supported families when the baby was born. We meet them 10 years down the line and they'll remember the exact words, whether they were good or bad. If they're good, brilliant. But if they were not, they'll still remember them for the rest of their lives. So it's just making sure the words we use are good words. Respect our decisions. It's not too late to terminate. It's easily fixed, you know. Parents should have the scope to change their minds, but not be pressured into doing so. Their decisions should be accepted and respected at all times. So we had a very recent case in one of the hospitals where mum was asked 6 times when she had indicated she wanted to go ahead with the pregnancy at every appointment. So it's just important that they're not pressured into doing so and that their decisions are respected and accepted. Words matter. The midwife, newly qualified, laughed awkwardly and said, I haven't had one of these before. I'm sorry. Please don't say I'm sorry or it's not your fault. Congratulate us on our new baby. So parents have just had a lovely new baby. It's so important that they enjoy the new baby and the focus is not just their Down syndrome. So your little gestures, just congratulating or saying, oh, you've got a beautiful baby, does mean a lot to our parents. So sharing the news, just a few pointers. So give yourself time to prepare. I've just put prenatal, postnatal because sometimes if families have already had a prenatal diagnosis and you meet them on the ward, they've just had the baby, they would have already done a lot of their homework. They found out lots of things. They might be ready with lots of questions for you. If they've had a postnatal diagnosis, they've just found out, they'll be in a completely different emotional state. So it's just, if you have that knowledge prior, you can help to support those families better. Use person-centered language. So whenever you're talking about a baby with Down syndrome, it's always the baby or the child first, and they happen to have a syndrome. And I'm going to share a lovely video with you soon about that. Interact with the baby, use his or her name, obviously, if you know that. Allow plenty of time, give them time to ask questions. Check that parents have actually understood. So don't use medical jargon and try and our website actually has really good information on what Down syndrome is, explained in a very simple way. So you can even point them to that because that's the way they can get that information in a much easily understood language. Be realistic about the wide range of possibilities for people with Down syndrome. So avoid, cliched statements like all kids with Down syndrome are happy or they all love music, which is not true. Inform the family about support services available. So even if you don't remember anything from today's talk, do remember Down Syndrome Scotland. We're here to support you in that journey when you're supporting families. Now, the Scottish Standard Care pathway for babies born with Down syndrome. So we partnered with our NHS Scotland neonatal colleagues to create this pathway. This pathway is intended for use by all health professionals involved in the care of babies born with Down syndrome. Now, it provides guidance on the importance of language when sharing news that the baby has Down syndrome. So that was our main contribution to that, as well as the significance of clear communication to parents to ensure that they receive balanced and accurate information. And obviously, the NHS colleagues have put in the clinical aspects that are required in the pathway. So this is a really useful document. It's also available on our website. It's also available on TURAS and other perinatal networks. So you can access this document through that. And I've shared the link with you, so I'm sure you can get that through the resources as well. This is our baby packs, which go to all maternity hospitals across Scotland. I don't know if you can see them, but they look like this, and they will have the business card of a family officer for that area. So we have family officers based across Scotland, So they'll have the contact details for that person. It's got really lovely stories from families. It's got a little booklet about babies. There's a little insert which talks about, which goes from the ages 0 to 18 months, talks about things like holding the baby, feeding the baby. So lots of really useful tips for families. And there's also a flyer on breastfeeding. This is one of our parent volunteer mums, Abby, and this is her lovely daughter, Esther, who's not little anymore. She's started primary school. And Abby has written a lovely blog, and her story is also in our baby packs. And she's happy to be contacted if mums want to talk about breastfeeding or if they need any sort of support. So she had a very difficult journey, and so she's written her story and shared information. I've also put links to different resources that families can tap into. I know the Downs Heart Group is not there anymore, but there's a lot of information on supplement feeding and things like that. And you can contact us if you need any more information as well. This is just information on the support services we offer. So we have our family support teams that are based across Scotland, and most of our family officers are parents of children with Down syndrome. So they have that credibility, they have that first-hand knowledge, information, and that professional background. So they can come in and support families in the hospital. They can do a home visit. They can help you with your child disability payment forms. So usually we would ask families to wait till the child is a year old, but if the baby has lots of complex needs, is in hospital for long term, then they would come and help you in the hospital to fill it out. We run Makaton signing for babies, ABC, which is our communication program, Achieving Better Communication, which runs from the ages of 0 to 25. And we also run some parent workshops. So there's all this information is on our website, so I won't spend too much time talking about it. I've already talked about our family support service, which is the heart or the core of our service. This is the support we offer to professionals. So if you are interested, if you have teams that would like some more training and teaching sessions, we are happy to deliver them online. And we always have a parent speaker, so you'll always get the parent perspective when we're doing these sessions. And all our sessions are free for you. So just get in touch with us. We run lunchtime talk series every last Tuesday of the month. And this is just for half an hour, 12 to 1, and you can join them. They're free. We invite health specialists, health professionals to talk about different topics. So it can be something related to breastfeeding, to dementia, to lots of different topics. So you can drop into one of these. Our branches, local branches across Scotland, 10 of them, and they're all parent-led. And they provide support locally to families. So they run toddler groups, they run water babies, they run drama clubs. So lots of different things that families can dip into. This is just resources for health professionals. So our People First language resource, which talks about the importance of language. So I'm just going to share this video quickly. Is it Alenso? I forgot the name. Angelo, please could you play the Mind Your Language video?
I care about words.
Because words matter.
Words have power.
Words can build or destroy.
Help or hurt.
Don't call me Mongo.
Or monk.
Never ever say that.
Never, ever.
Don't call me that.
Don't call me spaz or retard.
Or backwards.
These words hurt me.
These words are wrong.
Don't call me a Downs person or say he's Downs.
Down syndrome is not a disease. It's a genetic condition.
I am not ill, handicapped, or suffering.
Down syndrome is a small part of who I am. There's so much more to me.
I am a son,
A workaholic, a waitress,
a brother,
And a dancer. Call me Teresa.
Stuart,
Cher, Sam,
I'm a friend.
an actor,
a writer.
an ambassador for Down syndrome.
And I'm a Harry Potter fan.
Words matter.
Mind your language.
Think about what you're saying. See beyond my Down syndrome.
Thank you, Alonso. Angelo, could you also share the video from Bev, please?
My name is Bev, and I have three wonderful daughters, Faith, Maya, and Chloe. They're 17, 15, and 13, and my youngest daughter, Chloe, has an extra chromosome, which we just feel makes her extra special. So far, thankfully, Chloe hasn't had any serious health complications associated with Down syndrome. And while I know that there are lots of children who do, today I can only speak from my own experience. Chloe did have reflux up until she was around 15 months old, and she does have low muscle tone. I was 29 when I was pregnant with Chloe. I chose not to have any testing done with any of my pregnancies, as I knew it wouldn't make any difference with regards to continuing with the pregnancies. People have asked me since having Chloe if I wish I had had the testing done, but I'm glad I didn't, because I think I would have Googled everything and potentially scared myself stupid. My pregnancy with Chloe was no different to my other two pregnancies, apart from feeling slightly less movement than I had done with my other two. We decided to find out the sex of the baby, but at that time there was no scan beyond 12 weeks here in Inverness, so we had to go to Aberdeen. I do remember I signed a form to give permission for our GP to be notified if they had noticed any concerns, but we didn't hear anything, so I presume at that point that none were detected. Chloe made a speedy entrance into the world, almost had an unplanned home birth with her. Our initial checks were all good. We were told that we could go home later that day, providing feeding went well. I had breastfed my other two children for a full year, so I couldn't understand what I was doing wrong this time when Chloe wasn't seeming to feed very well. I called a midwife to come in during the night of our first night to assist with feeding, and she asked for paediatrics to come and see Chloe. At that point, Chloe was taken away briefly, but there was no real communication then as to why she was taken away. When she was brought back to me, we were told to just continue to feed with the tube and syringe, and that they would come back to see how she was doing in the morning. I remember one of the paediatricians asking about a picture that I had at the side of my bed of my other two children, and thought how lovely it was that she was chatting to me about my other two. I realise now that she was probably looking to see if there were any similarities between my other two girls and Chloe, but at that time I didn't make any connection. Chloe was taken away again to a room next door the following morning, where I was asked to accompany them. There was no prior suggestion of anybody being with me for this. When we were in that room, Chloe, I remember her being laid out on the massive bed in the ward, and they told me that they were concerned with some aspects of her appearance. To which I asked what they were concerned about, and they said the bridge of her nose, the almond-shaped eyes, the appearance of a longer tongue. Told that there was a possibility that Chloe might have Down syndrome, and that they were going to be taking blood from her later that day to test. At that point, I tried to call my husband, but there was no speaker in the phone in those days. So it was actually my sister who was with him as he was driving the car. So she was the one who heard the news first, and she had to then tell him. He came into the hospital, and when I had been taken into the ward by myself with Chloe, the doctor had said that if Chloe's dad had any questions that he wanted to ask, that just to give him a shout when he came in later on. I do remember her dad asking if there was anything that I had wanted to ask that I hadn't at the time. And my only question at that point was, if she does have Down syndrome, how long will she live for? I almost couldn't bear to hear the answer though. So when the doctor did come in to speak to him, I took myself off for a shower, thinking, I don't know if I actually want to hear the answer to this as much as I did want to know. We were allowed to go home the following day. I persevered with breastfeeding despite being told it might not be possible, and did successfully manage to feed Chloe until she was just over a year old. 3 days after we took her home, we were called in to get the results, and it was confirmed that Chloe did have trisomy 21. I remember at that point just being bombarded with new medical terms and statistics, how there's a 40% chance that she would have a hole in the heart, so we would have to go back in a couple of days later to get a heart echo done. and all the complications to expect: the speech delay, motor skills, ear, nose, and throat problems. And while I'm very aware that all this information is important and we do need to know it, there was very little said about the fact that our new baby at that point just needed all the things in life that any baby needs: love, interaction, sleep, and fed. I wondered about the impact that it would have on my other two daughters after hearing this, and how their lives would potentially change to cater for all these potential issues. I do remember feeling hugely overwhelmed, but we were both massively positive in spite of everything. The midwives and health visitors were fantastic and hugely supportive. I think we probably underestimated, though, just how much Chloe would be able to do and how much she would achieve. Having two older siblings has undoubtedly had a huge effect on this too, as Chloe wants to do everything that they can and sees no reason as to why she shouldn't. Life with Chloe, we do have our challenges, and there have been many new things to learn and understand: medical terms, departments of the hospital, visiting professionals, appointments, different medications. But every milestone is a massive achievement, and seeing Chloe overcome obstacles is something really special. Speech is still a huge barrier for Chloe, but we use Makaton and the ABC Teach programme with Down Syndrome Scotland, and she finds her own ways to make herself heard. We've met lots of other people with various disabilities and had lots of support and made lots of lovely new friendships through this. Down Syndrome Highland meetup groups that we go to, and we've had lots of support and advice from Down Syndrome Scotland, which we've all benefited from as a family. Personally, for me, having Chloe's taught me to slow down and take every day as it comes. I'm less of a stress head planner these days, and I no longer sweat the small stuff. I'm more patient, and I appreciate all the little things in life so much more. I do wish that I hadn't spent so much of the early days of having Chloe worrying about my other two daughters. They're grown up to be understanding, inclusive, and caring individuals, both keen to pursue a career in the healthcare profession. And I do think a lot of this has so much to do with the input that they had when Chloe was younger and all the different people they met. They all share an amazing bond. I wish I had known that, in fact, they would be Chloe's biggest fans and that she would be theirs. Chloe loves to dance and takes part in competitions around Scotland with the same dance team as her two sisters. She's got the most fantastic sense of humour, and her compassion for others is often quite humbling. She's had a positive impact on so many people. When my niece was pregnant a couple of years ago, she was asked if she would like to have blood tests done, and she said no. And when the midwife questioned why she was so adamant that she didn't want any testing done, she said that she had a cousin who had Down syndrome, and she would actually count herself very lucky if she had a baby with Down syndrome too. Chloe's making steady progress at school. She has good support and just loves being part of everything. The one thing that I wanted to highlight most today, I think, is probably the use of language and how important it is. So quite often we're told that there's a risk of a baby having Down syndrome. The definition of the word risk is that it's a situation involving exposure to danger or the possibility that something unpleasant or unwelcome will happen, a person or thing regarded as a threat or likely source of danger. Parents will hang off every word that you say, so the word chance is far less negative. If that could be used instead of risk, I think it would make a huge difference to how we hear things right from the first stages. What would we change? About Chloe, absolutely nothing. We would like to change society's perceptions surrounding Down syndrome. They have improved for sure, but I think there's still a long way to go. Education is vital. The more understanding there is, the more acceptance and inclusion I think that there will be. And the negativity associated with having a child with Down syndrome. For us, it was far from the end of the world, but the beginning of a whole new one.
Gosh, Vashali, those two videos are both very powerful in different ways. And I love the picture of Chloe with her sisters dancing. That's so lovely. And really a positive image about, it's something that could be less less positive, which is fabulous. Now I'm just waiting for some questions to come in. We've got a little bit of leeway here. And so far, Claire, hello, Claire. And I'm looking over here because this is where the comments and questions come through from Paul. And Claire says, what a brilliant video. And I think she means the Mind Your Language, which is really good, really strong. You get a feeling of they're not just kind of voiceless victims. They are people just like you and me who want to be valued, which is fabulous. And then Carol Goddard, hi Carol, also says so powerful. So I'll just give a minute or two for you if you have any questions for Vashali. I personally think what a lovely presentation, because your description of the 3 types of
Down syndrome.
genetic bit of it was so clear. And I love the whiteboard, and which really made it very simple and very understandable, which was lovely. And also the World Downs Day, that was Downs Syndrome Day. That was a really clever way of doing it. And thank you for all the resources. Now I'm just going to reiterate that a lot of those links and lists of things which are focused on Scotland, NHS Scotland, but are accessible. The World Wide Web is ours, all of ours, so you can access information from there. The only thing is some services to signpost people to might be different if you're in other parts of the UK. That's the only thing to kind of be aware of it. Now, Claire says, thank you. Chloe's beautiful, as is your whole family. She loves that. So she wants that to go back to Bev. And then Carol also says, thank you so much to Bev for sharing Chloe and their family story. I think I get the feeling, I'm not sure if there's a lot of questions coming. So I think you've been so clear and made us and challenged us. And what the other thing which was quite interesting with the questions, and I know actually it's a learning point for us on the hour, because sometimes we have the time to do a little poll. And this might have been a very good topic. So I know Vaishali was very wanting to get interaction from the audience, but actually we're really good. And Paul was feeding through most of the questions that the not true, the myth, people not sure about some of them, the ones that I was a mixed response. And then Paul says the audience agree with Sue. Well, that's nice. Thank you very much. Because I think for me, when you were talking about the whole kind of profile of people with Down syndrome, babies with Down syndromes, I thought we do tend to kind of think it's one thing. And I think what I've learned from you this evening, or not learned because I knew it, but it emphasized for me the difference. Just like anybody else, people are going to be different, and we all have those lovely unique differences and human kind of challenges. So that was really, really helpful for me. Oh, I've got more comments. We've got Laura. Hi, Laura. And she says, wonderful videos, very, very powerful. And Tamara, hello, Tamara, says, very informative. Thank you, student midwife. Fabulous. That's lovely. I don't see any questions coming through. So if you had a question, you'd have to be fast. Well, I have a feeling, Vashali, you could answer anything. I really do.
If I can't, I can take it back and I can come back with the answer. So,
well, that's even better. So I think because I'm very conscious of time, we're a bit over the 8 o'clock. Now, as I said right at the beginning, please, if you want, this is a really good session to share with your colleagues. And if you're in a student group, because any genetic, it seems to me, any genetic issues can be really complicated, and you can get clouded by everything that's included in the profile and think, I don't really understand. And I think if you share Vashali's presentation, I think it's so clear, it makes it, you can understand it, hopefully. And I think the sort of all the profile, the age, the age limits and all that sort of thing will be very useful. And I think this would make a really good discussion group activity for student midwives, also for midwives, because we can always learn something a little bit different, can't we? Which is great. I think now I will just say a huge thank you to Vashali and to Bev, because and to the people in that lovely video. Very strong, very strong. And thank you for sharing your knowledge and your skills with us. And I'm sure that for those of you who are watching, that you have more questions or suddenly have a question tomorrow morning, I'm sure Vashali will be very happy if you send her a question. And if you don't know, just put it in the forum and we'll pass it on to her. I want to say a big thank you also to Angela, who's behind the scenes doing magic to make sure everything's recorded beautifully so that you can access this again to your colleagues and to yourself. Thank you also to Paul, who's been throwing things to me, trying to follow the discussion, which was fantastic. And also, just to reiterate, for those of you who like to be up at 6 o'clock in the morning on Friday morning, maybe to listen to the podcast, because I know this goes out on podcast, it'll be there, we're ready for you. So if you like to do that. And also you'll have this whole presentation will come out on the newsletter on Wednesday next week. So that'll be great. So next week, we're going to be looking at postnatal care with Dr. Leslie Turner. And that's going to be a sort of combination looking at things like staffing levels and maybe the effect on midwives, the effect on mums and babies, which is fantastic. I'm also going to, just because we're coming to the end of the month, we're coming to the end of September. Now, you know, those of you who watch this often will know, I love this wonderful Action for Happiness calendar. You have a little calendar every month, different thing. And it's a really good thing. And I especially find it useful because in our lives, we're very busy, and especially most of us who are women, balancing so many different things and sometimes forgetting just to stop and have a think. And each day you have a little activity to do and a little activity to think. And I think the one for today is accept yourself and remember you are worthy of love. I just thought that was lovely for the day. So that is also, there's a link on the resources for that. It's a really good thing to share and to think about for yourself, because the biggest thing for me now is to say, thank you for joining us. I hope you found this useful. Thank you again to Vashali. Take care of yourselves. Take care of yourselves because you're precious. And give your loved ones a little extra hug tonight, just from me. And we'll see you same time, same place next week. Take care.
Thank you.